Hello and welcome. I'm Adele Gauthier from Breast Cancer Foundation New Zealand, and tonight we're talking about tamoxifen and AIs, or aromatase inhibitors. Before we get started, some housekeeping. I'll change that slide. Molly, could you click on that screen? Yeah. There we go. Great. I encourage you to make the most of the chat box tonight, which you'll see at the bottom of your screen. You might have a taskbar or status bar there. If you can't see that, you might need to move your cursor down to that area to make it appear. You'll see a chat icon there. Click on that to open the chat box. And if you have any technical problems, you can type details of that there, and our support team will get in touch. You can use the chat box during the webinar to ask questions, which we'll get to later. And you can also chat to other people there. Don't worry about missing out on any information while you're chatting, because the webinar will be on our website tomorrow and we'll send you a link to that. Right now you should be able to see the slides and the panellists in a smaller box on your screen. If you want to make us bigger for some reason, you can just drag the corner of that box. So tonight we're talking about tamoxifen and AIs, medicines that your doctor might have recommended you should take for 5 years or even more after breast cancer. If you're watching this webinar, there's a good chance you're wanting some help with managing side effects. Well, you may never actually learn to love these medicines, but we hope that by the end of the night you'll have some idea of how to live with them with the help of our 3 speakers. So first we're going to hear from patient Barney Berry, then we have Dr. David Porter and Dr. Megan Overby, who'll tell us more about why these drugs matter and how to handle some of the side effects. First, we're going to hear from Barney, who was diagnosed with breast cancer in 2016 at just 32 years old. She takes an aromatase inhibitor called exemestane. Barney, tell us a bit about your breast cancer treatment and what life is like for you these days.
So I was diagnosed with infiltrating ER positive, PR positive, HER2 negative cancer at 32. And I had a right mastectomy with nodal clearance followed by chemotherapy and radiation. And then after that, I started on monthly Zoladex, weekly exemestane, weekly Risedronate, daily exemestane, which is the aromatase inhibitor. And that was, just over 2 years ago now. So in terms of how it felt, to me, in the beginning, I really couldn't distinguish any symptoms as such. And over time, maybe 6 months or a year in, I started to notice subtle changes. And not just me, but also my loved ones started to notice subtle changes. And these changes were both physical as well as psychological. And on the physical side, some of the things I began to notice was achy joints, especially areas of injury. Like I have a really bad shoulder and neck from a prior injury, and that I almost describe as echoing pain now. So I started to notice that that pain was a lot worse. The stiffness when I sit down for too long, and if I don't move, like when I'm working at my desk, getting up again is like not fluid. It was very stiff. My hair took a lot longer to grow back after chemo. It wasn't as thick as it was before. And also I was a little bit jaded, maybe a bit foggy, and very tired. The psychological effects were severe mood swings. So I was almost taken aback by them because they arrived unexpectedly, out of nowhere. I was experiencing a lot of sadness, a lot of anxiety, and that anxiety was starting to keep me awake. So what prompted me really to seek help was some of those mood swings were starting to affect my life and our life as a family. Sorry, I just need a moment. Yeah. And well, one of the things that
Maybe just take your time.
So it still resonates with me was I really one day went off at my husband over something that was so small, so minuscule. And I remember standing in the kitchen, completely losing my mind at him. And that to me was time to seek some help. Sorry, compose myself. And so it was a bottle. He broke a bottle while doing the dishes. I loved that bottle, and that was it. I lost my mind. And my kids were watching us, and I thought, this is something that I really need to seek help for. So I went on a run after that, processed my emotions, got some happy hormones going with some endorphins, came back, and I said to him, I'm going to go back and see the psychologist that I saw over chemo to help me through. And when I saw the psychologist, what she made me realize was that I have actually got the self-awareness of recognizing that this, what I call the exemestane ogre, is starting to take over me. And when I see those signs, really, some of the things, being self-aware, that I can do is, before that vortex takes me over and I feel like I can't control myself, is to physically ground myself. So I either physically hold my hand and squeeze it, or I get my husband to put his hands on my shoulders and just say, it's okay, take 5, take 10. And depending on the circumstances, I might walk away and take 10 minutes to myself just to breathe and process my emotions in isolation, or I might go for a walk or a run just to kind of give myself some time. And when I do that, it makes me realize that the frustration or the anger I'm feeling is over something that's minuscule, and it actually doesn't matter in the greater scheme of things. But also being able to do that exercise, which I now do really regularly, is keeping my joints really lubricated. It means I'm agile and I'm moving really well. So that's been sort of a bonus to it as well. The other thing that the psychologist pointed out was that because I wasn't sleeping very well, and what was happening was I'd wake up in the middle of the night at 2 a.m. and not be able to sleep. And what I would do was look at my phone, and that was making my tiredness worse, and then the exemestane compounded it. So now I practice really good sleep hygiene. So I go to bed on time. I don't look at my phone before bed. I read a book, and I just have better sleep. And if I do bolt up at 2 a.m., then I don't have my phone close by to look at. The other thing is being present, so mindfulness. I felt the foggy brain was coming from either living in the future, worrying about things, or living in the past, regretting things. So if I'm in the present, then I'm concentrating and I'm not so foggy. So I guess the one thing that has stood out for me is seeking help when I recognize that I need help. While these things have become part of my practice and I do them now without thinking, I know that if I feel like things are getting on top of me, then I am not afraid to ask for help, whether it's a counselor or a psychologist. I feel like there shouldn't be any stigma from doing so. Yeah, so that's my experience.
Wow, great. Thank you so much for sharing that with us, Fani. We really appreciate that. Guys at home, don't forget to use the chat box to talk to each other, or to submit some questions that we can see later, or to watch the conversation. Now we're going to hear from Dr. David Porter, a medical oncologist at Auckland City Hospital who specialises in breast cancer. David, how do these medicines work, and what are the common side effects that you're talking to patients about?
I'll get to that, but one thing I would say is that I'm not expecting anybody to love these things, but they are your friends. They're not perfect friends, though, and you do kind of need a survival guide to get past, a length of time on them for the time that you do need them. So starting off with what is hormone therapy, it's prescribed for people who've had receptor-positive breast cancer, and there are two forms. There's the older drug tamoxifen, which is just over 50 years old now, which blocks the action of estrogen, and in doing so it's effective both in premenopausal and women after the change of life. The aromatase inhibitors started off life exclusively in postmenopausal women. They reduce the non-ovarian production of estrogen, so they're only effective by themselves in women after the menopause, but in younger women, you have to use them either with surgical removal of the ovaries or ovarian suppression for them to work. So why do we do it? There are two indications really. The first one is adjuvant treatment, which is treatment immediately after surgery to prevent recurrence of breast cancer in other places of the body, as well as the breast. The questions that we'll be discussing later about duration of treatment apply only to this situation. It's also used for the treatment of advanced disease. I haven't mentioned fulvestrant, which could equally come into this discussion because that's not funded by Pharmac and is not easily available in this country. So how do we choose? You want to choose the most effective treatment, but you also want to do it the least harm. And comparing those keeps me awake at night, at least, because you're comparing apples and oranges, and sometimes it's actually hard to decide which is the more important thing. So the factors in that decision are the things that determine the risk of the breast cancer coming back in an individual person. So the size of the tumour at operation, what it looks like under the microscope, whether it's well behaved or a bad actor, number of lymph nodes involved and receptor status. Genomic information such as Oncotype DX or Prosigna is more relevant to chemotherapy than which choice of hormone treatment. And there are reasons not to, and I'll come back to those later on. How long for? What I tend to do is for women with very low risk, small node negative cancers, I tend to give them tamoxifen for 5 years because I think in many ways that's better tolerated. High risk, an aromatase inhibitor in older women for 5 years, and ovarian suppression for 5 years in younger women. Now that's a standard that's highly questionable. So what are other standard options? In the past, we've tended to use tamoxifen for 2 to 3 years and then completed the 5-year course by changing to an aromatase inhibitor. That's something that's getting to be a bit passé, although its results are not dissimilar to 5 years of an aromatase inhibitor. There's a few earlier relapses with that strategy. Doing it in the opposite direction has never been common, but it's something I think can be considered in particular people. And tamoxifen for 10 years. There's still evidence coming in, and there will be cases where we would suggest an aromatase inhibitor like exemestane, letrozole, 7 to 10 years. But what this talk is more about, I think, is the realisation that about half our patients do not complete the treatment, and that's mostly due to side effects. So the best treatment is what can be tolerated. I often say, trying one of these drugs is like going out clothes shopping. You know, you try something on that looks really good, but you find it doesn't fit, you choose something different, because it's more important to be on something than nothing for as long as possible. So the side effects of tamoxifen, and what keeps me busy during the day is hot flushes. It keeps women busy at night mostly. That with tamoxifen, particularly in younger women, is the major side effect that we deal with. I've seen the occasional person with mood swings. When they happen, they can be really dramatic, as we've just heard, and I've saved at least one marriage by taking a person off endocrine therapy. But it should also be realised that mood swings at the time that we're prescribing tamoxifen actually are quite common, and that's because we're dealing with a situation which nobody finds any fun, the diagnosis of cancer, and what does it mean for that person. Cognitive changes are reported. Weight gain seems to happen to a small number of people where it can be very significant. And there's about a doubling of the risk of clots, which is most important if you're laid up for a long time, for example, after you've had an injury or on a long journey or surgery. Aromatase inhibitors, the things that I see most commonly are joint aches. They happen to up to about 80% of people in my clinic, and probably about 1 person in 6 stops them within a few weeks of starting these drugs because of that side effects. And the longer-term bone mineral loss is important. There's an excess of about 1% per year of women who have a fracture while taking these drugs, and the long-term implications for the skeleton of bone mineral loss, I don't think we've fully defined yet, but are certainly there. Cognition, poor memory can also be an issue on these drugs. Hair thinning and hair loss is also a problem. And atrophic vaginitis, where the lining of the vagina becomes more fragile and easily hurt and sometimes bleed, is an issue. And that's a bit more controversial to manage in women on these drugs than it is on tamoxifen. So how do we do it? Well, mood swings, sometimes it's just a matter of waiting it out. Sometimes counselling is a very good idea, but sometimes you simply have to stop the drug because it's so overpowering. Cognitive function, we don't have a great answer for. There is evidence that if you stop the treatment that the memory improves. We've been doing some research on trying to improve things by other ways, including a study that was supported by the Breast Cancer Foundation using magnesium. I don't know that we can say that that treatment works for that particular reason. Weight gain, sometimes it's better to change to an aromatase inhibitor than tamoxifen. Joint aches, the treatments that people talk about are using anti-inflammatories like aspirin, not so much, Brufen, any of these other drugs that you can get across the counter at the chemist. They help, but I wouldn't want a person to be on those for 5 years. Activity, going out for exercise is a great way of helping fix this, but it's not the complete answer for a lot of people. And sometimes you do have to change medicine to tamoxifen, which is less prone to this side effect. For prevention of bone mineral loss, I tend to use tamoxifen in low-risk cases. In the past, we've done bone density monitoring, but more commonly these days, we simply start a course of bisphosphonates like the Resedronate that you were taking. But we also recommend that people have their dental work updated before we start that for a variety of reasons. What do I do for hot flushes? I've used a bit of magnesium. It's a simple preparation you can buy at your local supermarket for about $12 for a packet of 60. Whether or not it works is controversial. There's a randomised study that says that it doesn't, but I've certainly seen some people who have benefited from it, and it's a very safe, low-risk thing to do. Probably the drugs that have been best described to help with it, certainly the best is estrogen, but you can't have that, are the antidepressants. I've always found that very difficult to convince people to take because they have side effects. And certainly the drugs, fluoxetine, which is also known as Prozac, and paroxetine Arapax, you probably should not take while you're on tamoxifen. One of the things that I've used a lot in the last couple of years, and I've found revelatory, is gabapentin, just a single dose at night, and that seems to help with sleep. Pregabalin I haven't used, but recently I've started a couple of people on oxybutynin after a publication last year. And for one of those women, it's been life-changing. She went from being unable to sleep at night, waking up 5 or 6 times a night for the last 4.5 years, and falling asleep during the day in work meetings, and unable to concentrate, to feeling perfectly fine. So they can be very good. These things I've talked about are all drugs, but we shouldn't overlook the effect of exercise in reducing hot flushes. Moderate your alcohol and coffee intake, and other conservative measures like wearing loose-fitting cotton clothing. I don't want to go too much into these because I'm stealing your thunder.
Great, thank you, David. That's fantastic. And as David said, Megan Overby is going to talk to us a bit more about some of these medications. Just before we get on to that, I see some of you in the chat box are sending in questions. Just to say that it's really helpful if other people can see your questions as well as the panelists. So where you've got the little to all panelists near the bottom of your chat box, you can just click on that and change it to all panelists and attendees, and that way other people can see what questions are being asked, which is super helpful. Okay, so now we're going to hear from Dr. Megan Overby. She's an endocrinologist at Auckland DHB and in private practice at Fertility Associates. Megan, endocrinologist is not a word that many of us know. Can you tell us what that means before you move on to telling us a bit more about these drugs and how you deal with them?
An endocrinologist is a hormone specialist, Adele, so we deal with the hormone component of what happens within the body. And my specialty interest is reproductive hormones, so I do a large amount of menopause. So let's start off talking first about what symptoms can be attributable to menopause. And the most common classic symptoms that we talk about are the flushes that women experience often during the day and the night sweats that they experience at night. And we collectively term these the vasomotor symptoms, and I've talked about VMS through the slides that you're about to see. Sleep change is really common. Night sweats can disturb sleep at night, but sleep can be disturbed even without the vasomotor symptoms. And we're increasingly recognising that the menopausal transition is a time of mood vulnerability for women. You know, we've been very good to date of recognising the postpartum period as a time of mood vulnerability, but we need to understand that the menopausal transition similarly can drop mood and cause real problems with changing anxiety levels as well. Arthralgias, David talked about them with the aromatase inhibitors, and we certainly see that, but you can also get arthralgias just from being estrogen deficient. And formication, which is where women describe insects moving under their skin, and fatigue. Vaginal symptoms are extremely common. This is the one menopausal symptom that gets worse rather than better with time, and I'm going to talk about that in a slide or two. And the studies show that women with breast cancer tend to be more likely to have symptoms than women who don't have breast cancer, and the symptoms tend to be more intense. And I think every experience is different, and the worst thing we can do is try and judge another woman, either for her symptoms or the medical decisions she makes around her symptoms, because the experiences that women have are quite different. So why do women with a breast cancer diagnosis get worse symptoms? Well, I think there's many different reasons for that. David's given us a really good rundown of the endocrine therapies and why they cause estrogen deficiency and can absolutely cause symptoms in association with this. Chemotherapy will often cause ovarian dysfunction. And if you are younger when you have your chemotherapy, you are more likely to recover ovarian function, but that will absolutely cause symptoms of estrogen deficiency. And many women who have had a breast cancer diagnosis undergo having their ovaries surgically removed. And those women go from very normal estrogen levels for their age to really no estrogen within about 48 hours, and they are particularly symptomatic. So it is important to think about your triggers. What we're aiming for here is symptom control, and the more that we can do to help ourselves will make a big difference for symptom control. Some women quite like to keep a diary, and it helps them work out exactly what their triggers are so that they can avoid them. Dressing in layers, wearing natural fibres so that the sweat is absorbed will all make a difference to your ability to manage. And I think many women find relief by these kind of techniques. In terms of medication, these are really the options that are non-hormone treatment. And in the third row across there, I've mentioned the efficacy, which really means the number of women that could be expected to be helped with this medication. I think probably we've all got the most experience with the SSRI group of medications that increases the concentration of a neurotransmitter called serotonin in the brain. And the reason is we've only really recently got funding for gabapentin for this indication, and so we've all used the SSRIs for a long time. And about 60% of women could expect to find symptom relief, mainly with the vasomotor symptoms. But of course, the SSRI group of medication has the added benefit of improving mood for a large number of women and controlling anxiety. Gabapentin, we're all very pleased to have funding for, and now also will help about 60% of women. It tends to be a different 60%, so it's absolutely worth working through these options when you're bothered by symptoms. And as David mentioned, gabapentin has the added bonus of causing some sedation at night, and so typically we use a nighttime dose. Clonidine I've listed up there because it's such an old medication, it's been around forever, but I've never actually seen it achieve symptom relief for women. And typically what happens is by the time you get flush control, the side effects are so difficult. And one of the newest players and one of the areas of interest for the future is the stellate ganglion block, and I'm going to show you what that is in the next few slides. So there is a bit of evidence to suggest that cognitive behavioural therapy and psychology support can help menopausal symptoms. But actually all the other alternative treatments out there and herbal treatments have really not been found to be helpful. Black cohosh, which is a soy-based estrogen, initially a few years ago was thought to be helpful for mild menopausal symptoms, but studies after this have been disappointing, and there's no safety data in women who have had breast cancer. So let's talk about the serotonin medications first. David's already quite correctly told us that if you're taking tamoxifen, then paroxetine and fluoxetine are not a good idea because tamoxifen probably doesn't work so well with those medications. And actually the newer options of escitalopram and citalopram are generally kinder in terms of side effects, and it tends to be where we all start. Generally these medications are very well tolerated and they work quickly. If you haven't seen an improvement within about 4 weeks, you're not going to see a significant improvement in flushes. Side effects can involve some initial anxiety for the first few days that tends to then settle and go away. And if you know about that and aware of it, then you can tend to ride it out. Sometimes some sexual dysfunction, drop of libido, difficulties orgasming, and sometimes problems with emotional blunting. Patients will tell you that they can't feel the lows anymore, but they can't feel the highs either, and some women find that a bit difficult to deal with. In terms of length of time of how long you should be on these medications, well, it really depends on the length of time of symptoms. And if you're getting symptom relief, then every couple of years you should probably try and wean off your medication and just see exactly where your symptoms sit. And the serotonin medications really should be weaned off because there can sometimes be a withdrawal syndrome that sits with these group of medications. Gabapentin is a medication that's widely used overseas in the States and England and Europe to treat the hot flushes of menopause, and our local experience is gaining with this medication. We've had funding for it for about a year, 2 years, roundabout. And this is really all around treating the vasomotor symptoms. It generally is very well tolerated. You can get side effects for the first few days that will often settle, and we start on low dose, between 100 and 300 milligrams at night, and then titrate up depending on morning sedation. If you carry on and increase the dose, the side effects will normally settle, and typically we use between 600 milligrams and 900 milligrams to treat flushes. Stellate ganglion block is currently available in the private system in Christchurch, and we're trying to bring this to Auckland at the moment. This is when local anaesthetic is injected into the stellate ganglion, which controls the sympathetic nervous system, and it sits just in front of your V6 of your vertebra, C6 vertebra in your neck. And this is done under ultrasound guidance, and what happens on that side that has been injected is you droop your eyelid and your pupil dilates for just a short period of time. That's the temporary Horner's syndrome that is discussed on the slide. And that will happen to everybody, hopefully, because that's how we know it works. But actually it's very well tolerated and no side effects other than that have been described in the studies. And you can see with this graph down the bottom here, the relationship to vasomotor syndrome symptoms. It's not coming up on the slide. No. Okay. The line across the bottom is the improvement in vasomotor symptoms, and the one across the top is the sham trial after about 6 months of treatment. So it looks interesting, and you can have repeated treatments if you need to. So this is what David was talking about with regards to vulvovaginal atrophy. In terms of the picture there, this is a slice through the vaginal wall looked at under a microscope. And the picture on the left that is labelled premenopause is a woman in her 20s or 30s with a regular 4-weekly menstrual cycle. And the picture on the right is somebody who is 10 years after menopause with no estrogen. And you can see all those lovely mucus-producing cells have disappeared, and this becomes painful, friable, and when it sits around the urethra can lead to urgent urinary urgency and frequency, and sometimes some urinary tract infections. And we clearly want to keep women as healthy as we can. And there's absolute treatment available for this. So you should be talking to your GP or your oncologist or your breast surgeon about these symptoms. There's a range of different options. You can look at using a vaginal lubricant during intercourse. You can look at using a moisturiser, and I've put Replens up on the slide there, but there's 3 or 4 different options that are available over the counter from any chemist. And a moisturiser is something that you use regularly, not just when you're having sex. And this helps improve the vaginal wall moisturisation. Or you can use vaginal Ovestin, and this is an estrogen cream. You should talk to your oncologist before you do this, however. There is a very small amount of vaginal estrogen absorbed in the first few weeks after treatment, and then when the wall thickens up a little bit, the levels of estrogen in the bloodstream really don't get above postmenopausal levels. There's some concerns about them with aromatase inhibitors, but for the most part, with many women who have had breast cancer, mostly oncologists are happy with this option. So what about the use of hormone replacement therapy? I've been asked to comment on this, and I think this is a very tricky area. The scientific evidence for HRT after breast cancer is very sparse and it's very limited. But in selected situations, there are women who feel that the benefits of the use of hormone therapy outweigh any risk. It's always a multidisciplinary discussion, and it's always an individualized decision. So how do you access all of this information? Well, general practitioners are very well used to treating menopause with non-hormone alternatives, but there is also your oncologist and your breast cancer surgeon who will use these medications widely, and many regions will have a menopause clinic who will also be able to help you.
Great, I'll take that back off you. Thank you so much, Megan. And as you can see at the bottom of that slide here at Breast Cancer Foundation, we also offer free counselling, which for some of you might be useful around maybe that cognitive behavioural therapy or around hand and mood swings and so on. You can see a link to our website there. And I guess just the other point on referral to an oncologist, I think a lot of patients may be given their treatment by their surgeon and so on, so maybe not have even consulted with an oncologist. And I think, David, your point would be that you guys are have a special interest in this.
I don't think it's necessarily specifically the exclusive domain of an oncologist. I mean, in Auckland, we have the great fortune of having medical oncology running the endocrine therapy, but there are other places throughout the country where they've got very, very expert surgeons who are also doing this. So I don't think it specifically matters what the person's job title is. I think it matters whether they actually are interested in this aspect of care, rather than just saying, I've prescribed it to you, and if you don't like it, well,
yeah, right.
So on, yeah.
Okay, great. So we're going to open up now to questions from you at home. So as we've said a couple of times, you can use the chat box to ask your questions, and we'll spread them out among the panel here. We do have quite a few questions to be getting started with. So David, the first one's for you. When's the right time to start taking hormone therapy, endocrine therapy after breast cancer?
My first philosophical answer is as soon as you can. There's no hard rule. There are some studies that say, that the benefit still can be achieved even if you take it, 18 months after your surgery was done. I wouldn't recommend that as a standard starting point. The idea is the sooner you get in, if there is any cancer still lurking in your body that we can't see, which is the thing that we're trying to treat with giving you adjuvant treatment, then the longer you leave it, the bigger it will grow and the more difficult the job will be. So the time that I have the greatest trouble with this is straight after chemotherapy, where people have had an early and very dramatic menopause and are not necessarily in a great state of mind or physical health to start it. So I'll often spend a little bit of time trying to manage those estrogen deprivation symptoms so that any additional ones don't become overwhelming, and that's sometimes a few weeks.
Right, thank you. And Megan, a question for you. What about hair loss or hair thinning? Is there anything you recommend for that?
Hair loss is a very common symptom. In terms of outside of chemotherapy, the things to think about with hair loss are iron deficiency. That will absolutely make hair loss worse, and thyroid dysfunction can change hair loss too. Estrogen deficiency can change hair loss. And again, outside of chemotherapy, we need to think about a testosterone level. There are medications that help with hair loss. There is topical Rogaine, which can be purchased over the counter. And then there are tablets which are not estrogen, so they suppress testosterone, which also can help with hair loss. So there are certainly options.
Okay. And Vani, you said you felt your hair was sort of thinner?
Yeah, so it took a lot longer to grow and certainly hasn't returned to its thickness. Fortunately, it's wavy and curly, so I mask the thinness.
Now, I've got quite a few questions here. What can be done about bladder weakness and regular UTIs, urinary tract infections?
I think any of the things that I listed on the slide with regards to treating vaginal dryness and irritation would be really sensible. Recurrent UTIs probably should have a GP or a gynecological examination and a consideration as to whether a renal tract ultrasound scan would be sensible, because there can absolutely be other causes. But thinking about vaginal symptoms is also really helpful.
I've certainly had more than one person who's had regular recurrent urinary tract infections, and when we've treated their vaginal atrophy, the problem has resolved.
Right, interesting. A couple of questions about taking a break from tamoxifen or from AI treatment. One question about taking a break prior to breast reconstruction surgery to reduce the risk of DVT or pulmonary embolism. If you do that, when would you restart? And similarly, someone else has sort of said they've taken a break off tamoxifen, now they're thinking maybe they should go back on. Is that a good thing to do?
There's no one answer to that. So for breast reconstruction or any other major surgery, we recommend that you stop taking it about 3 weeks before the procedure. My sort of pragmatic approach to it is, as soon as you're up walking again, start taking it again. Because once you're mobile again, your risk of getting clots reduces. In terms of coming off it and starting it again, I'll quite commonly do that if a person has a number of symptoms and we need to find out whether or not they should change treatment or whether or not this is their background situation. Remembering that 5 years is a very long time on treatment, 10 years is even longer, and during that time there will be some aging of the skeleton and other symptoms that people get. So sometimes it's necessary to take people off for a short time to find out whether it is the drugs that are doing it, and then try and find solutions after that. Most difficult decision I think some women face is the dilemma of if they want to come off it for a long time to get pregnant, and so we are increasingly doing that for younger women, because we're also starting to prescribe longer durations of treatment, and that would mandate that some women cannot have children if they're going to stay on that treatment for that long. So pragmatically what people are doing worldwide is taking people off so they can get pregnant and then go back on again afterwards. The question of whether you should restart, I think, depends on how bad the symptoms were that drove you to stop and what your risk factors were, and I can't comment on that as a general policy.
Okay. Megan, you mentioned that there's no evidence around soy and supplements and things like that for relieving symptoms. But if people do want to use phytoestrogens like soy, plant-based estrogens, is that a risk to them at all in terms of breast cancer?
I don't know that we know that. They're weak estrogens. That's what they are, and these tumours are estrogen receptor positive.
Yeah, I just say exactly the same thing. We don't know that they're safe. But the thought that always goes through my mind, if they do help hot flushes, is it because they're acting like estrogen? And if that's the case, then particularly if you're on an aromatase inhibitor, you may well be stopping the effect of your drug.
Here's someone who says she's been on tamoxifen since 2014 and is still having irregular periods, half yearly. Should she be expecting postmenopausal symptoms? She's 49 years old.
Not necessarily. About 20% of women will go through menopause and not experience any symptoms at all. So there's no hard and fast rule. About 80% of women who haven't had a breast cancer diagnosis will experience symptoms, and about 50% of those women will feel that those symptoms are affecting quality of life enough that they'll come and knock on somebody's door for help. So she may go through without any symptoms.
Right, okay. How long does exemestane stay in the body after stopping, especially if a lot of weight has been gained from that treatment? Is weight gain, is that tamoxifen? Or
Weight gain is more commonly tamoxifen. That's got a longer half-life than the aromatase inhibitors. Typically, the aromatase inhibitors, I think, have a half-life of around 6 hours. That's certainly true for letrozole, which is the one I most commonly prescribed. I'm not sure that I can give you an accurate figure, but it would be gone within days is the longest.
any thoughts around CoQ10 or chondroitin for joint review? Did you try any of those?
No, I haven't tried, no.
Yeah.
A few years ago, we tried to get a trial through what was then called the ANZ BCTG group, looking at chondroitin and glucosamine for joint symptoms. There's a lot of research out there that says that they're not particularly helpful, but there may be some brands that are. Unfortunately, getting good research in this area is just about impossible to do. We haven't got any answers for that, I'm sorry.
Megan, do you have any thoughts?
I don't have any more to add to that.
And here's someone who says, is it normal when on tamoxifen I was collapsing to certain smells like petrol or gas or perfumes, but since switching to letrozole has not collapsed? Is that something you've heard of before as a side effect?
No. But if it's not happening when you're on letrozole, I mean, I wouldn't look that gift horse in the mouth. Sometimes people start tamoxifen just after chemotherapy, which is really well described to cause changes in people's taste sensation. And so the question I thought when I first heard that, was that just a hangover from that? But I've never heard of it from tamoxifen by itself.
Mm. I think in the vein of what you said before, Megan, about some people not getting too many menopausal symptoms, someone has asked, are there any positive stories out there? And I think there are certainly a decent proportion of patients, do you think, who don't
get menopausal symptoms? Yes, I think there's many women that go through this that don't get bothered by symptoms. I only see those in the studies.
Right,
but,
of course.
You know,
they're
absolutely out there. They just don't come and see us.
And they probably don't watch webinars like this. Sorry to say that. Yeah, a bit of a skewed group here.
But the point of what we're doing is to try and make more and more people feel that whatever side effects they are experiencing are bearable.
It's manageable. And for the vast majority of women, it is manageable. You know, the medication works.
And I guess it's a message not to just accept it if you're not managing, then to ask for that referral or to see somebody else who might be able to help.
Yeah, I'd endorse that. You know, when I first started in this job, nobody ever finished chemotherapy, and now everybody does because we've got much better nausea control than ever we had before. And that has driven a big change, in my view, in the number of women who are cured. And if we can take that idea and bring it into endocrine therapy so that we are managing people's side effects so that they can bear to take these drugs and even thrive on them and not notice that they're taking them anymore, that has to be the goal.
That's certainly been my experience. As now it's like something that happens in the background, and I just take the drugs regularly and life continues without much hindrance there. Yeah.
And I think not being scared of using these non-hormone alternatives. There's a lot of people that are anxious about the thought of being on an antidepressant or worried about side effects. If you've got as far as actually coming and talking to us about your menopausal symptoms, you normally need some help for a while. Right. And these medications are effective for a large number of women.
Yeah, true. A few questions about what's the best time of day to take these drugs.
My advice is to put them into a routine so that you add them into, say, brushing your teeth in the morning or something else that you do every day. And in that way, you are more likely to take them every day because they don't do any good sitting in the packet. For some women, I say to them, if you're getting a lot of hot flushes, try taking the drug in the morning. And there are a few women who get nausea, particularly with tamoxifen. If they get that and they're not suffering unduly from hot flushes, sometimes a better time to take it is at night so you sleep off the nausea.
Right, yeah.
I take it at night because fortunately I don't suffer from hot flushes, and it's just become routine. I take it before I go to bed and I figure my body can rest while it does its thing. Yeah.
Right. Yeah. That's nice. Is it best to take tamoxifen with food?
Pass.
No? Okay. Let's see. Okay, what about symptoms? A couple of questions about symptoms of endometrial cancer, and someone's also asked about uterine cancer, but I'm not sure that's...
So the endometrium is the lining of the interior lining of the uterus, and it is true that tamoxifen does have that as a side effect. There's an excess of, the figure I carry in my head is 4 women in 1,000 who take tamoxifen for 5 years get that, and it's about 3% if you take tamoxifen for 10 years. Of course, you don't have any risk if you have a hysterectomy, and it's thought to be no risk if you're continuing to have periods. The first sign of that is a postmenopausal bleed, and it's important to respond to that and get it investigated so that if it does occur that we can do a hysterectomy and that's the end of that problem. It's a dreadful side effect of any drug to have cancer as a side effect, and it puts a lot of people off, but I've never seen it as a side effect in anybody I've treated. That is that rare, and I've done this for over 20 years now, so I've treated a person or two. But it should never be something that you take completely for granted as a doctor prescribing the drug. But the benefit of it is that it reduces the number of women who die of breast cancer by much, much more.
Right.
You were going to say
well, the only thing I'd add to that is that you can't ignore postmenopausal bleeding, and you need an ultrasound if you have it, but having a postmenopausal bleed doesn't always mean that you have endometrial cancer. Right. So you can't be paralysed by fear. No. You've got to come forward, talk about it, have the ultrasound and check it out.
I've seen a lot of people with postmenopausal bleeding, and I've never seen that. And we've investigated a lot of people, but usually there's a remedy for it. So it is important to manage even if it isn't cancer.
Still needs looking at. Great. Just on the subject of Ovestin, Megan, which you mentioned, here's one person has said it worked like magic for her. So that would be for the vaginal dryness and so on, is that right? She only needed it for a 2-week period, and the effect has lasted for a year so far. So that's a nice story.
Yeah, I'd endorse that. I mean, it's controversial in oncology circles, the use of Ovestin, but that story endorses the way that I use it, which is to use it in a burst for a couple of weeks and then use it again when it needs to be used again, and it doesn't have to be very often.
Right. A comment from someone who switched from letrozole to tamoxifen after, to letrozole from tamoxifen after a blood clot and has now been told to watch out for osteoporosis. If I do get osteoporosis, is that reversible? Is there anything I can do to improve my bones other than weight bearing exercise?
Yes, limit alcohol and don't smoke cigarettes. Keep on doing exercise. In practice, I think doing bone mineral density scanning is not a good way to manage this, because by the time you've diagnosed the problem of osteoporosis, there isn't a road back from that. So for most people who I prescribe letrozole, exemestane, Arimidex, they're all pretty much the same. I start them on a course of a bisphosphonate, so like rosedronate, or 6-monthly zoledronate, which is an intravenous infusion for 2 years to try and prevent that from happening.
Someone has asked if tamoxifen causes a dry mouth. Have you come across that?
Not in my experience.
I don't think I've come across that either.
No, it could be. Random. Someone else, I'm on tamoxifen, metaplastic HER2 positive breast cancer, premenopausal at 43. I've been on tamoxifen for 3 months and feeling terrible. Currently having a 2-week break. No energy, very foggy. I'm supposed to be on this for 10 years. It doesn't sound too...
Okay. So my advice is get back to see your oncologist, tell them what the problem is and say, what can I do instead? Because there are lots of options, too many to discuss briefly, but you should seek advice.
So after 3 months, you'd expect to be past some of those initial sort of...
I think the side effects of tamoxifen can persist for months or years. So when they're bad, you need another thought. What are the other options?
A couple of questions, Megan, about the Mirena IUD. I've had that fitted due to thickening of the uterus. Does this carry a risk?
I think it's a very effective treatment for endometrial thickening and is protective against endometrial cancer. In terms of breast cancer risk, the studies aren't really there, and the few that are of concern were slightly mixed. I use Mirenas a lot. I think they're a really good treatment for heavy, unpleasant bleeding. And I don't think that we are changing women's breast cancer risk, but the studies aren't extensive to look at it. Do you have a comment on that, David?
Yeah, again, I'm kind of out on a limb in my profession that I'm quite happy for people to use them in the right circumstances. There has been a few studies looking at Mirenas versus copper IUDs in women who haven't had a history of breast cancer, and there doesn't seem to be a risk associated with those. And there was a meta-analysis done by Helen Roberts, who's now retired, but did the last webinar with us, that seems to suggest that they are safe. So I'm happy for them to be used. I don't think it modifies the breast cancer risk.
And just to add to that, the copper IUD won't provide the endometrial protection. It has to be a Mirena.
Oh, okay,
Yes.
Interesting, good point. And what about, someone's mentioned here, a Mona Lisa device?
Oh, yes.
What is that? What is that?
So a Mona Lisa is a vaginal laser treatment, which might be interesting. We're waiting for the results of the randomised control trial to come out. So this is looking at vaginal rejuvenation. That slide I showed you with the vaginal change with estrogen deficiency, and this is a non-hormonal way of treating the vaginal change. There's been some observational work which looks promising. There's been some concern about some practitioners causing vaginal injury, but we're waiting for the randomised control trial, and it was supposed to be out at the end of 2018, so hopefully it's coming soon.
Oh, right. Yes, keep an eye out.
Watch the space.
Yeah.
Is that something people do privately?
At the moment, yes.
Okay,
Yes.
so that will indeed be very interesting to see, to get the trial results on that. Here's a question, does raloxifene have a place after 5 years of anastrozole?
Raloxifene has not really been used for the treatment of breast cancer. There is some evidence about it for osteoporosis, and it has a role there, but if you're looking forward as a treatment for breast cancer, I have to say that's unsupported.
Right, okay. Weight gain on tamoxifen, at what point should you think about stopping tamoxifen in regards to weight gain, or any advice on dealing with that?
I think if you're thinking about it, the best thing to do is go and see your whoever it is that's prescribing it to you and say, should I be on something else? The typical thing that I see with people is when they gain weight on tamoxifen, they gain it really fast, and it's often 10 kilos in the space of a few months.
Oh wow, yeah.
So it's usually a very easy situation to diagnose. In the early studies, the average weight gain of people on tamoxifen was the same as the average weight gain on the people who weren't on treatment on the same trial over the same period. So it is a subset of people, I believe, that put on weight like that.
Is it what you find too, Megan?
Well, estrogen deficiency, it doesn't cause weight gain like that. The trials show that women who become estrogen deficient put on about 2 to 3 kilos of weight, but that tends to be central, and it's because of estrogen changes and also metabolism slowing down as women become estrogen deficient. So I think it's a slightly different presentation to what David's describing.
Right, just looking for some extra questions here. We've got quite a few. The questions come up again, David, about taking a break from, if someone has been off their treatment for a year or two because of side effects, is it good to go back on? Would you mind just covering that again? They might have missed
Okay, so I think the important thing is what was the reason why you came off, and I don't know the answer to that. Now, how serious was it, and how long have you been on it? What risk is there of the breast cancer coming back, and most importantly, if we put you back on it, how much is that risk going to be changed by? Because if the risk is there, it's never going to be changed. There's no point being on it. So there's no one answer to that, and I think that varies from person to person. I think the only thing I can say that's sensible is go and see your doctor and talk about it.
Great. Megan, maybe one for you about vaginal discharge. Is that a common issue, and what can people do about that?
Vaginal discharge can occur with vaginal ovestin. It's quite common, and it's all about the fact that you're bringing back estrogen and bringing back those mucus-producing cells. Vaginal discharge is generally, healthy vaginal discharge is generally related to estrogen levels.
Okay.
It is reported quite a bit on tamoxifen.
Oh, okay, right. And magnesium for cognitive issues and memory and so on?
We're trying to publish that study. Yeah. I don't think that we can say that magnesium in the small study that we did was proven to be helpful with that. We seem to see the same level of benefit in people who weren't on magnesium, and so all we seem to be measuring was people doing the same test twice and doing better the second time around. We would like to have done a bigger study, but we've been trying to get funding for that for a couple of years now, and I don't think we'll ever achieve that, I'm sorry. So the answer with that particular line of research is that we don't know, but I don't see a lot of harm in taking it. I do have the theory that if we can improve people's nighttime hot flushes, that we improve their daytime performance.
Just one important question that a few people have had. There's been a change in the brand of tamoxifen that's subsidised at the moment for Kiwi patients, and some people have felt a change in their side effects as a result. Can you comment on that?
Yeah, look, I wouldn't be too concerned about the effectiveness of the treatment. The way that the drugs are funded are that you have to prove that you have 20 milligrams of tamoxifen in your tablet, and that's easy to do. The manufacturer of the new brand is an international, well-respected manufacturer, so I think you can rest assured that the product is what they say it is.
Great. Okay, well, I'm being told it's time to wrap up, and actually I think amazingly we have pretty much got through all the questions. If we haven't quite got there and you'd like to talk to one of our nurses tomorrow, give us a call on 0800 BC Nurse during office hours. But now it just remains to say thank you very much to Vani, David and Megan for joining us tonight. That's been super helpful. And thank you very much to all of you at home too for contributing your comments and questions. And it's been great to see a few people say that you've been given some really good ideas and you're about to go back and talk to your doctor about things and so on. So that's fantastic. In the next day or so, we'll send you a link to the recording of this webinar if you'd like to watch it again or recommend it to somebody else. Thank you again for joining us. Good night.